Hello, ladies and gentlemen, and again, it's a pleasure to participate in the PCRI symposium. It's really been a wonderful tradition over the years, and I've had some very memorable experiences, probably of which one of the most memorable is having the piano sprung on me at the end of my talk back 3 years ago. And despite my playing, they invited me back, so I'm happy to be here. This is Toronto looking at its best, Sky Dome CN Tower. It's become a beautiful international city, and I really welcome visitors. So I'm going to focus on active surveillance, kind of what's happening. It's become a very active field. My disclosures, I'm going to mention briefly the products of both exact imaging and Mere Scientific, the high-resolution ultrasound in the case of exact, and the Sentinel assay. And I received research support, and I'm a consultant to both. So today we've got real progress in a whole slew of areas related to conservative management of grade group 1 and higher prostate cancer, a lot better understanding of the molecular genetics of grade group 1 or Gleason 6 or pattern 3, they all mean the same thing, compared to higher grade cancer. I'll come back to this. Patient selection, what is the impact of age and race and family history and so on. The importance of germline testing, particularly for DNA repair defects. Imaging, obviously MRI has been a game changer, but new imaging modalities like high-resolution ultrasound and PSMA are both having an impact. The role of biomarkers, both the strengths and the limitations, I don't use them very much. I'll explain why not. They do have a role in some situations. It's quite important. Predictive nomograms. So people have modeled surveillance compared to intervention, and essentially these have shown that first of all, the robustness of the approach, and also using clinical parameters to identify patients who are at risk, for example, who are at higher risk for having higher grade cancer in their prostates. I'll come back to that too. Long-term outcomes. So a criticism for at least 10 years after we first reported was, you're reporting too soon, you guys wait, you'll see what happens. The patients are going to start dying if you wait long enough. And that has simply not happened. And now we have many hundreds of patients, probably at least 500 patients in the collective prospective series who've been followed more than 15 years. And there is no cliff of mortality. Patients continue to do well. Follow-up strategies. This is an area where there was a lot of heterogeneity and differences in practice. These are starting to get more consistent as people share ideas and experience and decide how much is necessary, how much is not. A very fascinating area here is the tumor microenvironment and how some environmental and dietary and other influences influence the tumor microenvironment and alter the rate of proliferation and invasiveness of these cancer cells. So I'll mention some of the recent data on this. And finally, and this has been a longstanding interest of mine and of course Mark's, but dietary and other innocuous interventions in men on surveillance and how you can actually not only improve their general health, but reduce the risk of prostate cancer progression, often with the same intervention. So I'll cover a lot of this over the next 40 minutes or so. This is a scientific talk. I've tried to target it to a level of informed, scientifically literate lay people, but just some acronyms, PCA for prostate cancer, GG for grade group 1 is Gleason 6 now. We've changed the lingo for those who are new to this. It used to be called Gleason 6, now it's grade group 1. The main reason for this is people would hear Gleason 6, which is the lowest Gleason score, and their interpretation was, okay, I'm 60% of the way to the grave. Whereas hearing there are 1 out of 5 is much more reassuring and is actually much more accurate. Grade group 2, Gleason 7, and so on. OS for overall survival, CSS, cancer-specific survival, the likelihood, in other words, of not dying of the cancer, progression-free survival, the likelihood that the disease is stable without evidence of new disease showing up somewhere, PFS, AS for active surveillance, ultrasound. And this, I'll just explain what this forest plot is. This is how, in the medical field, we display huge amounts of data very concisely. So this is an example. Each one of these lines is a clinical trial. And it shows, for example, in each clinical trial, how many deaths. These are randomized trials. So, for example, in this trial, this set of trials, these patients got a steroid, these got placebo, and this shows the likelihood of dying in this case. The longer the line, the greater the confidence limits. The larger the square, the greater the number of patients. So you can see more patients, tighter confidence limits, and vice versa. And then down here, you see what's called the effect size, which is what is the impact of this treatment on, for example, reducing mortality. And the size of the diamond is the kind of confidence limits or the uncertainty. So I'm going to show a few of these, and just so you're not completely bewildered by it, it's a very useful technique for summarizing, in this case, what did the 7 trials show that studied this question? Okay. So now on to the topic. So it's really been an amazing journey over the last 20 years, from a great deal of pushback against the concept of conservative management. Patients are going to die. This is not safe. It's not ethical, etc., to really now widespread acceptance all over the world. These are each regional guideline groups, NCCN in the US, the consortium of AUA, ASCO, and ASTRO, it's a radiation oncology. This is medical oncology. The Canadian Association, Europe, Japan, Australia, everyone has adopted active surveillance as the standard of care for grade group 1 prostate cancer. There's an active surveillance aircraft. I believe PCRI paid for this out of their research foundation. Mark, you can comment on that later. But no, this has really been an amazing consensus that's developed. There was a bit of a political foo-for-all earlier this year when NCCN changed active surveillance as the indicated treatment of choice to one of 3, surgery, radiation, or active surveillance for grade group 1. And there was a massive pushback, and they actually flipped back, and now it's once again considered the standard of care. I think the reason for the flip-flop initially was there was concern. There are patients who should be treated, and I'll come back to that. So always for these groups, the question is, how binding is the recommendation? I think that's what drove that transient change in the recommendation. So I thought, this is kind of an overview. I'd just give a little bit of the history, one slide. So this goes back to a meeting that I had with 2 pals of mine who are radiation oncologists at my center, Sunnybrook, Richard Chu and Cyril Danjou. And I think it was no accident. Some of you may have read Walter Isaacson's book, The Innovators, which is about the development of the computer. And it really is multidisciplinary collaboration where you get people from different fields coming together that sparks fly. So here was a urologist and 2 radiation oncologists, and we assigned ourselves a task by the end of the lunch to come up with some strategy to reduce overtreatment of low-risk prostate cancer. So we came up with this idea: why not just follow the patients, track the PSA, repeat the biopsy, treat the ones where the PSA rises rapidly or their grade progresses. We never thought it would come to anything. And I got a grant of $35,000 from a brand new research foundation, the Prostate Cancer Research Foundation of Canada. And boom, we were off. And then 5 years later, we had our first publication. This was not such an original idea. I had trained with Whitmore, who was kind of a giant in the previous generation before me at Sloan Kettering, who coined the aphorism, "Is cure possible when it's necessary and necessary when it's possible?" Meaning you can cure the patients who don't need treatment because they have very slow growing cancer. And in the guys who have aggressive cancer, you tend to fail. And that basically emphasizes the primacy of tumor biology, and that is a very kind of fundamental aspect of the field of oncology in general, but it was considered quite revolutionary at the time. There were a number of guys, including Jerry Chodak, I would say above all, who promoted this idea of conservative management, but it was still a kind of either or. In other words, you do nothing or you treat radically. And we thought, maybe there's a middle ground. You don't have to deprive the patient of curative therapy if they look like they have more aggressive cancer over time. So that was the strategy. And now we have about 1,500 patients in the cohort. We've got long follow-up in a lot of them. Of course, many have died of old age, and a few have died of prostate cancer. And just the initial reaction, Pat Walsh, who was really the god of urology in those days, who described the nerve-sparing radical prostatectomy, said with conviction that the Gleason 6 patients were the ideal ones for this operation because they were the least likely to have disease that had spread beyond the prostate, therefore you were most likely to cure them. We have data from that era that almost 100% of these low-risk patients were treated with either radical surgery or radiation. And there were these very negative and personal comments like, Dr. Klotz will be responsible for these unnecessary deaths. So fortunately, I have a fairly thick skin. I also heard from colleagues, you'll never convince American physicians to stop operating or radiating. And all that, of course, proved to be untrue. So now it's a different world. What made it a different world? One thing was the U.S. Preventive Service Task Force recommendation against screening due to overdiagnosis and, above all, overtreatment. And that was, I would say, a real cold shower for those people who argued that all patients should be treated radically. And so they, of course, reversed this and went to a neutral recommendation a few years later based largely on the adoption of active surveillance. So the principle is no longer in dispute. And now at meetings where you have folks like me involved in debate and controversy and argument is how to do it optimally. Who's a candidate? Where do you draw the line? What should be the triggers for intervention and so on. So that's kind of the background. And we've learned a lot recently, like particularly in the last less than 10 years. First of all, molecular genetics. The Gleason 3 and Gleason 4, which are the two most common patterns, are like night and day when it comes to molecular genetics. 90% of pattern 3 have the molecular aberrations are essentially non-existent. They look like normal cells genetically. It's not 100%, it's 90%. But insofar as cancer is a genetic disease, the more the aberrations, the more aggressive the cells tend to be. This is very reassuring. The implication of this is that these cancers are non-metastasizing, and that is also supported by extensive worldwide clinical evidence. There's almost no cases out of really hundreds of thousands where a pure Gleason 3 or grade group 1 that's been treated with surgery, so you've had the chance to go through the whole gland pathologically, there's no hidden higher grade cancers, that these go on to recur and metastasize. They can invade locally. They don't metastasize, they can invade locally, and therefore they fill the strict criteria of cancer. Maybe I'll come back to this slide. I just kind of summarize what patients tend to ask in the clinic, but I can come back to that if necessary, because I'm going to cover a lot of those questions in my talk. So this is one study from a couple of years ago that looked at this issue of genetic alterations comparing grade group 1 or Gleason 6 to higher grade cancer. And they assessed what is called the average genomic risk, which is a metascore of genetic aberrancy. So this is called a heat map, and this is the degree of genetic mutations and aberrations in the cancers. And each one of these across the top is a cancer. So this represents many hundreds of cases The second line is the Gleason score. The light blue is grade group 1. The dark blue is higher grade cancer. So you can see as you move from left to right, this is favorable. On the left, this is unfavorable genomics on the right. It goes from light blue to dark blue, but it's not quantized. In other words, you got a few light blue lines out here in the worst genomic category. You've got a few blue lines, which is interesting, with very favorable genomics. That's another story. And the data was that for grade group 1, 2% were in the highest AGR quartile. So what's going on with those 2%? There's another basic observation in biology that the outliers often hold the clue to what's really going on. 2% are the patients probably where their Gleason grade group 1 is about to switch to grade group 2. You get genomic alterations as a rule before you get changes in the histology or in the pathologic appearance of the cells. So as soon as you have any elements of grade group of Gleason 4, so that's grade group 2, which is 3 plus 4, 7 times the likelihood of having really adverse genomics. And another major development, and this is quite ironic in my view, because this project, which is called a SPORE, which is a very well-funded team grant that usually involves 6 or 8 different teams around the country working in the same general area, led by Bill Catalona, who at University of Chicago, who was the most fierce and consistent advocate for treatment for everyone, and the opponent of active surveillance for many years. Basically, he saw the light eventually and now leads this study looking at which genetic germline factors, meaning present in every cell in your body, predict for progression to higher grade cancer. So they pulled together almost 6,000 patients, 28 centers. We were one of them. I was happy to cooperate and collaborate with him. And they've identified, by doing whole genome sequencing in these 6,000 patients, it's a huge undertaking, 18 variants associated with progression to higher grade cancer, 15 never previously associated with prostate cancer at all. And they developed this 269 variant genetic risk score. So in other words, the patient sends in blood or saliva. It's a bit like 23andMe or color.com, if some of you are familiar with that. And so they characterize the germline variants and are able to stratify patients according to the risk, if they're on surveillance with grade group 1, of being diagnosed with higher grade cancer. And it really stratifies them quite widely. And I just emphasize, this is the first study to come out of this major initiative, just published within the last 6 or 8 months. And we're going to hear a lot more about this. So this is kind of the germline approach to risk. Just some of the more recent data on outcome. This is from the Hopkins group, 1,800 patients, median follow-up 5 years, but many of them followed from 10 to 15 years or more. The prostate cancer mortality, 1 in 1,000 at 10 and 15 years. Now, who are those guys? They are the guys who had a very aggressive cancer at the time of diagnosis, which was missed on biopsy. It happens. And probably those cancers had already metastasized at the time of diagnosis, and the patients really wouldn't have likely done any better even if they'd been identified and treated radically right at the start. But again, 1 in 1,000 is such a favorable proportion. It's very reassuring. And now the proportion of patients who are treated is somewhere around 1/3 at 15 years. We think this is going to go down going forward as we get better at stratifying patients from the start with imaging. A lot of this data reflects pre-imaging results. This is another recent group from Sloan Kettering, 2,900 patients, 2664 were grade group 1. And I just want to emphasize these two lines here. The blue line is the rate of upgrading. The orange line is the likelihood that patients were treated. It's the same. So the laudable thing that the Memorial Sloan Kettering group has done, and we have done the same, the only reason to treat patients is for upgrading to higher grade cancer. In other words, presence of pattern 4 or 5, not for PSA kinetics, not for a biopsy that shows more grade group 1. And that is the strategy that makes sense at this point. And there, the metastasis rate, 1.5%, still very low, although higher than the Hopkins group. And this is largely because they were more inclusive in terms of including somewhat higher risk patients. The question that often comes up, what about men who are very young, say patients who are age 50 or 45 who have a 40-year life expectancy? Is it safe? What about those with a strong family history? So the message is it's still safe. In fact, active surveillance actually makes more sense in younger men for two reasons. One is the loss of erectile function with treatment is more of an issue, obviously, for a 50-year-old than a 70-year-old, rightly or wrongly. And second, high-grade cancer tends to develop with age. So younger men are much less likely to be harboring higher grade cancer. So in a sense, it's a safer strategy in the younger men, which is kind of the opposite of what you might think. So this was a collaboration between us and the group at Harvard, more than 400 men under age 60 on surveillance, and basically no difference in intervention rate, progression rate. The fact that they're younger doesn't mean they have more aggressive disease. It's actually the opposite. They're less likely to harbor higher grade cancer, and almost no deaths in this whole group. And then race. So race does have an impact, and mainly for reasons that are not completely understood, but that are probably largely genetic. There are differences, for example, in the structure of the androgen receptor, which is a key molecule involved in the development and progression of prostate cancer between races. Black men seem to be more likely to harbor higher grade cancer. So if you find grade group 1 in African American, you have to remember that their likelihood of harboring a higher grade cancer is higher, about 10 or 15% higher. However, if you look at the likelihood of a bad outcome, the likelihood of developing metastasis or of dying of prostate cancer, it's still virtually zero. So these men absolutely should be offered active surveillance. It should still be the standard of care. It's just they have, at this point in time, as far as we can tell, a modestly increased rate of being found to have higher grade cancer and requiring treatment. The next special group is the group with DNA repair defect mutations in their germline. So I'm hoping that people are somewhat familiar with this now. The most important of these genes, there's about 10 of them, but the one that's best known is called BRCA2. And this is relevant in both prostate and breast cancer. And the DNA repair pathway, as the name suggests, is responsible for repairing mistakes that are made in replication of the DNA every time a cell divides. And we have about 1 billion base pairs, and the likelihood of a mistake in any one base pair is around 1 in 1 million. So it's quite common to have these errors in replication, but fortunately our bodies have a mechanism, a molecular pathway, there's actually several of them, that identify and correct these mistakes. So what happens in the sporadic situation where there's no mutation, you gradually, over a long period of time, get loss of some key, what are called tumor suppressor genes. You get acquisition of some oncogenes that are cancer promoting, but it takes 10 to 15 years, and that's the kind of typical time course for progression of prostate cancer. Whereas if the patient has one of these mutations in the DNA repair pathway, like BRCA2, as soon as you get the initial inception of the cancer, boom, all hell breaks loose. You get this explosive accumulation of mutational events over a very short period because the repair mechanism is faulty. And you can appreciate that if you diagnose grade group 1 cancer and you think you're going to follow the patient for the next 15 years safely, that is not likely to be the case if they've got these BRCA mutations. And there's only a little bit of clinical evidence for this now. We know a lot about the pathways. This is one study from Hopkins, 26 men with BRCA or ATM mutations, kind of the same pathway. You can see here the likelihood, HR is the increased risk hazard ratio for developing higher grade cancer with the patients with the BRCA2 mutation compared to normal is almost 3 times greater. So it's here, it's 80% at 10 years. It's plausible to me that they missed 20%. It's actually more like 100%. So these guys should, in my opinion, and most people's right now, should not get active surveillance. They should be treated even if they have only grade group 1 prostate cancer, and mostly treated with surgery. They're only about 5% of the population, so it doesn't apply to most men. But when you do find these germline mutations, it has implications for the whole family because these are inherited mutations. So finding a BRCA mutation or one of the other ones in a patient means that the children should be tested and other relatives potentially. It's quite meaningful and important information. It's become quite inexpensive to screen for this now. You can do it through one of the commercial companies like Color.com or Invitae for only a few $100s. We now are pretty much screening all our active surveillance patients for these DNA repair mutations. The next question is, how important is it to have close follow-up? So some of our patients agree to the serial biopsies. We don't do it very often, but we do a second biopsy 1 year after the initial diagnostic biopsy, and then now about every 4 to 5 years. Used to be a little more often. We went back and said, did it make a difference? And, you know, there's very few examples in the whole field of oncology where how you follow the patient really has been shown to make a difference in terms of survival and mortality. And somewhat to our surprise, it did. So the red is the patients who complied with the protocol. They had their biopsies. The black is the patients who said, no way, I'm not having another biopsy. I don't care what you say, or they disappeared. And they had a very significant increase in their rate of progression. This is metastasis-free survival, in the rate of prostate cancer mortality, and even overall mortality. So patients do need to be followed. The biopsy is still important, although much less often than we used to do it. And I think this just emphasized that point. The next topic is imaging. So traditionally, we did biopsies systematically, guided by conventional ultrasound. 12 cores was the standard. 1 million biopsies a year in the US. But the ultrasound, conventional ultrasound, is good for imaging the outlines of the prostate. And you can imagine it could help you guide the needle into different parts of the prostate. But it was not useful. Unless you had a huge cancer, you really couldn't see it by ultrasound. So, of course, MRI has had a huge impact. This is, I like this case because it's so illustrative. This is a guy whose systematic biopsy showed 1 positive core, 10% grade group 1 or Gleason 6. In the old days, we might have repeated his biopsy, probably wouldn't have found much. Now he gets the MRI. There is the lesion right at the top. There's no way you would ever hit that with a systematic biopsy unless you really had the luck of the gods. But now he has MRI, targeted biopsy, showed Gleason 4+3. He has a radical prostatectomy, great big aggressive cancer in the anterior prostate, which is actually quite common. place for these to hide. And there's his totally insignificant grade group 1 cancer that was the one found on the biopsy. So you can appreciate kind of writ large that MRI has had and continues to have a major impact, but it's not perfect. I'm just going to emphasize the limitations, which is not to say it's not tremendously useful, just it has limitations. So it's not real time. The patient has the MRI, then it's reviewed by the radiologist. If he needs a biopsy, there has to be a fusion process where the MRI image is kind of superimposed on the ultrasound image. It requires a specialized radiologist with a lot of expertise that takes time to develop. Treatments and biopsies can cause artifacts. It misses lesions. It's expensive. In many parts of the world, you can't get an MRI for the average patient. There's just no access to it. Some patients are claustrophobic. Some have pacemakers or hip implants. They can't have an MRI. Insurance can be a barrier. It underestimates volume. So this is from a center of excellence showing that the average volume on MRI of the cancers is underestimated by about a third. In this study, the average estimate was 1.6 cubic centimeters by MRI, 2.4 when you actually took out the prostate. So you have to take that into account, that it tends to show, it doesn't show the margins of the lesion very well, and it misses lesions. So another report from a center of excellence in 588 men who had an MRI followed by surgery and had whole mounts. So you could actually see exactly where the cancers were, how did they correspond to the MRI. And the shocking thing, at least to me, was that in men who had more than one cancer, so this is the multifocal prostate cancer scenario, which is the norm. Most patients' prostates, if they have significant cancer, have more than one site. If the cancers were less than a centimeter, 80% were missed. If they were 1 to 2 centimeters, 50% were missed. So MRI misses a lot of cancers, particularly the smaller ones. And this is from Sloan Kettering showing the performance of MRI in men who had a biopsy and an MRI at baseline, and then 3 years later had another MRI and another biopsy. And again, the disappointing thing, in the men whose MRI was completely stable, a third of them, despite the stable MRI, were upgraded to grade group 2 or higher. So you can't just sit quietly with your negative MRI or stable MRI and assume that nothing is happening. So that's where I think there's been some progress in this area. I'm very enthusiastic about this novel technology called high-resolution micro-ultrasound. So the difference between this and conventional ultrasound is the megahertz, the frequency is 29 million hertz per second, versus conventional ultrasound is 6 to 9. So what that does is it improves the resolution to 70 microns, which is 0.07 of a millimeter, compared to 200 microns or 0.2 of a millimeter with conventional ultrasound. And why that's so important is because the ductal anatomy of the prostate, the prostate is a gland, it's secretory, it's full of ducts. And the key change with cancer is loss of the ductal anatomy. That's why you see it on MRI. And that's why you can see the cancer with this high resolution ultrasound. You don't see these changes with conventional ultrasound. It kind of looks, feels like a normal ultrasound machine. The cost is in the same ballpark. And just some examples, this is conventional and this is high resolution in the same patient. And there's really, you see details here that you simply don't see conventionally. And you use transperineal biopsy, different techniques, stepper arm or template. And this is just an example. So here's the prostate on ultrasound, and there is the lesion. Now, you would not expect to see this with conventional ultrasound. So if you were doing this the way it's been done for the last few years, the patient would have an MRI. The lesion would probably show up on MRI. And then the radiologist, let me just stop this, too distracting. The radiologist outlines and superimposes this image on the conventional ultrasound. That's called fusion targeting. And you hope it's done accurately. Whereas here, you see the lesion. So about 80% of the time when it's visible on MRI, it's visible on ultrasound. And there's no question you have accurately targeted that lesion. And this is a publication of mine, which was the initial experience from the first centers who started using this. And despite the fact that a lot of these centers were still on the learning curve, the sensitivity of the ultrasound, this is sensitivity on the top and specificity on the bottom. So the sensitivity, meaning the accuracy with which it finds cancer if it's present, was actually better with ultrasound than MRI. The specificity, meaning if it shows something suspicious, how likely is that to really be a cancer, was about the same. And now there's some actual more mature data from, this is a center in Milan that was rigorously blinded to the MRI findings, and basically the ultrasound performed just as well as the MRI. So this is for each level of abnormality. These are 5 out of 5. So very suspicious lesions on Primus is ultrasound, PIRADS is MRI. Basically for each score, the likelihood of finding significant cancer, which is the brown, is exactly the same. Of course, it's a lot cheaper than MRI. It's a lot more available, and it's really very complementary. Not going to replace MRI, but it's a very useful tool. I just talk briefly about how the biopsy is done. So for approximately 40 years now, 35 years anyway, biopsies have been done with transrectal approach. And only recently has the technology become widely available to do it with transperineal approach. And the basic problem with transrectal, it's nice in a way because the needle goes directly from the rectum into the prostate, but you're taking basically a sterile needle, you're putting it through poop and then putting it into the sterile prostate, and that causes infection and bleeding not infrequently. And there's even a rate of mortality, which is somewhere less than 1 in 1,000, but more than 1 in 10,000. And it's simply too high. These are typically healthy patients. So it's a little easier to target, but overall, once one acquires the skill set, transperineal is equivalent. And here's some trial data showing that whether it's randomized trials or observational studies, the accuracy of, this is again one of these forest plots, the accuracy of transperineal and transrectal is the same. So we should switch. And this is, to me, a very compelling story from Norway. So this is the wife and mother of this Norwegian guy, Roar Gilbranson, who had a transrectal biopsy and got acute infection or sepsis and died. A healthy guy. And his wife and daughter found out about the alternative and were so outraged that they mounted a public relations campaign. This is from the front page of a Norwegian newspaper. And they got the public on side, and essentially almost overnight, transrectal biopsies disappeared from Norway, and now 100% of the biopsies there are done transperineally. And we need to, I would like to see this transition take place in United States and Canada, but without the public outrage. So we need to, in my view, we need to adopt this as a profession. What about intermediate risk disease, expanding the boundaries for surveillance? Well, I mentioned at the start that Gleason 4 pattern, you can't be so confident that the molecular genetics are favorable. They can be. And in fact, many grade group 2 cancers, which is a combination of 3 plus 4, but primarily pattern 3, are indolent. However, our experience, we were very inclusive with surveillance from the start. We had about 250 grade group 2 cancers, and 30% of them went on to metastasis at 15 years. So this is way too high. It was pre-MRI, pre-biomarker. The key thing here is the percentage pattern 4. If it's a very small amount of pattern 4, these patients basically should be treated as if they were grade group 1. If it's more than 5%, this is where the molecular biomarkers come in. Try and get a sense, does this cancer have favorable genomics or not? And also focal therapy is an option here. So this leads me to the next aspect of this, which is the molecular biomarkers. This is a huge field. You can look at protein, DNA, RNA. You can look at blood, at urine, at of course, semen is an obvious candidate for prostate cancer biomarkers that we're just beginning to examine semen as a source for molecular biomarkers. But first of all, just to show you don't actually need the really sophisticated and often expensive genetic biomarkers to get a handle on a patient's likelihood of having higher grade cancer. So this is a new nomogram from the Canary PASS group, which is a consortium based in the West Coast, biopsy risk calculator. So it takes readily available factors: age, BMI, PSA, prostate volume, time since diagnosis, maximum core ratio, what proportion of the core was involved by cancer, and gives actually a very tight reading for the likelihood of the patient being upgraded on their next biopsy. So this should be more widely used, in my opinion, freely available. Patients can look it up themselves, put in their own data if they have it. And then you have this huge initiative to develop molecular genetic biomarkers. These are the ones that are commercially available. They're in blood, they're in urine, and they're in tissue. So far, none in semen that are commercially available. They're not cheap. The tissue-based ones are in the $4,000 to $5,000 range. The liquid ones in blood and urine tend to be around $500 to $700. They're all trying to do the same thing, which is find the patient diagnosed with grade group 1 cancer who's actually got more aggressive disease, particularly grade group 2 or higher. You can see this is called area under the curve, or the accuracy, somewhere around 0.75 to 0.9. They haven't been compared head to head at all. So the differences here cannot be relied upon. They all work to some degree, and there's more coming down the pipe, particularly these liquid assays, circulating tumor cell-based assays, free DNA assays, and so on. The tissue-based assays are the ones that have a role in the patient with intermediate risk cancers considering surveillance. They haven't really caught on for the average grade group 1 patient. And the main reason for this is the limitation of something called tumor heterogeneity. So there's now many studies that document this. This is one of them. So this is a group of about 40 patients, each one of which had at least 2 to 3 individual cancers in their prostate. The average was 4. So the group dissected out each one of these cancers separately. And then they did what's called whole exome sequencing. So they analyzed the genetic sequences in those cancers. And they looked how often were the abnormalities shared and how often were they unique. And what is striking, the gray is the unique ones, the brown is the shared ones. 95% of the mutations, these are different genes that are involved in prostate cancer, 95% of the mutations were unique. So you do your biopsy, it shows grade group 1. The patient may have another cancer present in his prostate. It is, in most cases, not going to share the mutations that you find in the cancer you're examining. And so that's a kind of conceptual limitation. And why I think the liquid biomarkers have more of a future because they don't have that problem of sampling. The one that I'm involved in is called the Sentinel assay, which examines urinary exosome microRNAs. These are, this is RNA that's shed into the urine in exosomes, which are these tiny vesicles that are shed by cells. And just to, this is what the exosomes look like. A given cancer cell may shed thousands of these per day. They're extremely small. And they contain important biological material. And because the assay looks at more than 400 sequences, each one of whom is predictive, this has given a tremendous predictive accuracy. So here you see the accuracy compared to the other assays I showed, where this was like 0.75 to 0.9. Here it's 0.96 for the likelihood of finding grade group 2 or higher cancer, 0.97 for any cancer. Hard to do a whole lot better than that. Now, this is preliminary data, still needs to be validated, but this just gives you an idea of what is coming down the pipe. And what this lends itself to is what's called dynamic risk profiling, which means instead of doing a biopsy every few years, or even instead of having to image the patient every few years, you just do the urine test. If the test is negative, you follow the patient. If the test provides a signal that there's something going on in terms of significant cancer, then you may have to go back, re-image and re-biopsy. But if that pans out, that will make surveillance so much more appealing. Imagine a test with 97% accuracy that only requires a urine specimen. It would really enhance the appeal of this approach. The final topic I'm going to address is innocuous interventions. Can we prevent failure or progression or do something good for the patient? And why do this? Multiple reasons. The typical type A male doesn't like the passivity of surveillance. They want to feel like they're doing something to help. A lot of these proposed interventions do other things for the patient's health. And I think as a physician, if you can induce the patient to take on these other interventions, you do more for their health than you will by managing their prostate cancer. And maybe you can actually reduce the risk of progression. So there's two groups of these. These ones are the motherhood ones. Number one, stop smoking. Everybody knows this, but a patient who's newly diagnosed with prostate cancer, if the doctor spends 2 minutes telling him to stop, that's been shown to have a favorable effect on smoking behavior. That is the most cost-effective intervention in all of medicine. My colleagues need to do more of this, and I think that's really important. Regular exercise, I'll come back to that. And dietary modification, again, don't avoid obesity, not too much red meat, fruits and vegetables. Coming back to exercise, so this just summarizes the 8 different molecular pathways that have been demonstrated to be favorably influenced by exercise in prostate cancer, related to the levels of things like growth factors, something called epigenetic modulation, hormonal levels, the tumor microenvironment, and so on. But now we actually have some clinical evidence for this. A lot of that comes from preclinical studies, animal studies, and so on. Just within the last year, this randomized study in men on surveillance of the effect of intensive exercise compared to a pamphlet. So this was a small study, 52 men. The half of them got high intensity interval training, HIIT, which meant they had a trainer, they had phone calls, they were constantly harassed to exercise at a high level. The other group got just basically, yeah, you should exercise, which didn't have much impact. And not surprisingly, the group that exercised regularly had improved cardiovascular fitness, but their PSAs went down and their PSA velocity went down. Their PSA doubling time was more favorable. Their testosterone improved. So here's a small study, but with a prostate cancer endpoint of PSA and PSA kinetics. that's sort of favorable, pardon me, a favorable benefit. So this is a kind of pilot study, but it's really got people excited because it actually showed evidence of a benefit. I referred earlier to the tumor microenvironment. This is an amazing study for those of you who have a serious interest in this area. This is New England Journal publication from last year, Rathmel. And this, everyone knows, or the people in the field certainly know, that obesity is not good for prostate cancer. Obese men have a higher rate of prostate cancer metastasis, of more advanced disease, of prostate cancer mortality. Now, for the first time, we know why that is. And it's quite a fascinating story. So it turns out in obese men, there is a metabolic tug of war between the tumor cells and the immune cells, which are called the T cells, for these crucial lipid substrates that are required for normal cellular metabolism. The tumor cells basically grab all the free fatty acids, and the tumor infiltrating cells, the immunocytes that regulate tumor growth, are deprived, and their immune function is impaired. And this results in impaired tumor surveillance and anti-tumor immunity. This is why obesity is associated with an increased rate of prostate cancer, because it impairs cellular immunity. And I think this has been a really important step in our understanding of how this works. The next issue is diet. Should patients who are diagnosed change their diet? Should they become vegetarians or vegans or whatever? And so this has now been tested in a prospective randomized trial called the MEAL trial. Almost 500 patients randomized between vegetarian-based diet with counseling and phone calls, et cetera, and a pamphlet. And the primary outcome was a prostate cancer outcome, PSA kinetics and biopsy. Now, everyone knows, I think, that the diet over your lifetime influences your health. And the question is, once you're diagnosed with prostate cancer, does it make a difference? Sadly, it made no difference whatsoever. There was absolutely no impact of the dietary switch to vegetarian diet, either in PSA levels, PSA rate of rise, or upgrading on follow-up biopsy. So again, this doesn't mean that diet doesn't matter. I think what it does mean is that in the 2 to 3 year time frame, it probably doesn't make much difference once you're diagnosed. Maybe it's just too late. So a healthy diet is good, probably not going to make that much difference. I just tell patients, eat a heart healthy diet, avoid obesity. And then finally, last part of my talk is for those guys who really want to be proactive, who want to do something. They say, I hear this all the time. What can I do? There's got to be something I can do to stop this thing from getting worse. So there's 3 interventions. I emphasize that none of these are supported by controlled trials yet, although some trials are going on as we speak. So the first one is vitamin D. In northern parts of the world or polar parts of the world, vitamin D deficiency is ubiquitous in older people. They don't get enough sunlight. And there is a ton of data from mainly epidemiologic studies that low levels of vitamin D are associated with higher rate of prostate cancer mortality. So this is prostate cancer mortality by vitamin D level, a bunch of individual trials. There's the effect size, about a 10% increase in mortality. Nice thing about vitamin D is it's really cheap, it's harmless, and patients in general who don't get enough sunlight, I believe, should be on a vitamin D supplement, around a total of around 1,500 units per day. The next one is statin use. I know this is, of course, a long-standing interest of Mark's and of mine. There's a lot of epidemiologic data. It's the same story, that men who are on a statin have lower rates of prostate cancer metastasis, all-cause mortality, probably in part for the cardiovascular benefit, but even prostate cancer mortality. And why is this? These statins interfere with a pathway called the mevalonate pathway that leads to a number of molecules that stimulate prostate cancer proliferation and invasion. So aside from the cardiovascular benefits of statins, there's the prostate cancer benefit. I'm very pro-statin. I think all men, middle-aged men or most, should be on a statin, at least low dose, and certainly if they're diagnosed with prostate cancer. Mark and I have been planning a study for many years of statins in men on active surveillance, and I hope we're going to get around to it shortly. And then finally, there's the metformin story. Metformin has a favorable effect on, this is a diabetes drug, but it has both a favorable effect on prostate cancer growth and progression, both through a direct mechanism by basically stressing the cells metabolically. It kind of fools the cells into thinking the cells are starving, which has some benefits in terms of reducing the likelihood that the cells will proliferate, and an indirect effect by reducing some of the signaling pathways like mTOR and insulin signaling pathways that tend to stimulate cell growth. And there's a lot of data on this. We're doing a randomized study of this in Canada in men on surveillance, but this was a systematic review of the topic in more than 1.6 million patients, so just massive collective population, and that showed the likelihood of, this is a recurrence-free survival, of cancer-specific survival, the metformin patients who were mostly diabetics, but they had reduced rate of prostate cancer mortality. So, you know, it's a safe drug to take even if you're not a diabetic. And I don't really encourage it until we have actually direct data from randomized trials, which we'll have in a few years, but I do think it's likely of benefit. And then this just to show the adoption of active surveillance over time. The blue is the increased utilization of surveillance all through the United States, Southwest, Northeast, Midwest. Still some ways to go. In Canada, it's about 90%. In the US overall, around 60%, but it's trending in the right direction. So I think I'll leave it at that. Thank you for your attention, and I know we have some time for questions and discussion.